And last but not least, we have one lecture to close us off for the day, kind of to tie in everything that we've talked about. Awesome. Thank you, Dr. Gilberti. I'll have you lead us off for the evening.
All right. Thank you, Foss. So excellent discussions. I feel like we have to have a rematch for a lot of these matches, although for Mark and Ruben, it's probably going to be round 12 coming up. I'm Brian Gilberti. I'm from NYU Bellevue program, and I want to shift gears and talk about FDR for a second. He was our beloved president. He was a national hero. But what a lot of people don't know about FDR is that he was a victim. He was a victim of medical, not malpractice, but of medical practice. And here he is. Here he is at the Conference of Yalta. He's flanked by Churchill and Stalin as the Allies were marching towards their victory in World War II. But what nobody knows in this photo, or nobody could expect, is that within a couple of weeks of taking this photo, FDR would be dead. And he unfortunately would not see the demise of his nemesis, Hitler. He would not see the rise of the US from the ruin that was laid by World War II. And he missed all this by a matter of weeks and months, respectively. But why is that? Why would this man, relatively young gentleman, die so unexpectedly? You know, we found a smoking gun. Luckily, his physician kept meticulous notes of his care of the president. And we were able to piece together a plot of his blood pressure over the last 10 years of his life, which is here. And you see in the top part of the chart, you have the major world events, but in the bottom part of the chart, we have the documented signs of end organ damage. And as you could see going towards the right, FDR's blood pressure was approaching 300 over 190, a systolic of 300. Why? Why did his physician, a seemingly competent, patriotic physician, leave his blood pressure unmanaged? There were agents back in the 40s that could treat this. Why would this go without treatment? And the reason is, the main part of the reason is that back then, we thought we knew better. We knew that FDR had angina, and we knew that angina was associated with CAD. And there was some sort of critical stenosis somewhere in his coronary arteries. So the thinking was, in order to push the red blood cells past this lesion, we have to maintain the president with wildly uncontrolled blood pressure. And you know, maybe the higher the better. Now, to people on this call, this is ridiculous. This is a ludicrous conclusion to come to. And it's not a surprise to us that FDR died from a hemorrhagic stroke, but it was a shock to his physician, who on April 13th, 1945, when he passed away, said that it came out of clear sky. It didn't. This should be a cautionary tale for all of us here, to not fall into these traps and to not think that we can outthink medicine and try to reason our way to the justification of an intervention. Because when you get a bunch of doctors together trying to reason their way through how to best manage a patient, I bet they're often going to be wrong. And what's worse, they may even harm the patient. We must rely on data to support what we're doing. And the history of medicine is chock full of examples of this. And low-hanging fruit, it's easy to point out bloodletting since the beginning of what was considered medicine. But there are some silver-haired attendings still working who can remember a time when we were still bloodletting in the emergency department for fluid overload. It's not so far in the past. But a little more recently, hydroxychloroquine has been touted as an amazing drug that can squash COVID bigly and treat it and perhaps even prophylax against infection. Up until the best data we have shows that it actually doesn't help all that much with treatment or prophylaxis. You know, this, I think, hits a little bit closer to home because how many patients did we see in the trenches here in New York City during the height of the pandemic who were sent in or who came in on their own after being prescribed plaquenil and azithromycin by their primary care provider without doing any evaluation over virtual urgent care, to only see that their QTCs were going through the roof? Last thing that we needed. But again, to bring it back to the first floor where we're at, I want to talk about 3 examples specifically in which this type of thinking that we can rationalize our treatment has actually worsened care. And I'm going to talk about how it's creeped into our care for hemorrhagic strokes. for cardiac arrest and for trauma. Now, I think anybody who looks at these images is scared, and it'll prod your amygdala just taking a look at the one in the middle. At least it does for me. And when these images show up on your PACS, it just confirms what you feared the most. And it's only natural for us to want to intervene, to do something. This is wretched pathology that threatens the patient's life and well-being. So we want to do what we can, and not just stand there, to improve the chances of survival and also neurologically intact survival so that the patient could go home and complete their ADLs. But when we try to think of what we can do to change this once this has already happened, then some people point their finger at maybe it's medications, maybe aspirin and Plavix, and those patients we can focus in on those and hopefully get better outcomes with those. And I understand how we arrived at this conclusion because 25% of patients who have hemorrhagic strokes are on these medications. And patients who are on these medications have a 27% increased odds of death compared to those who are not on these medications when they have a hemorrhagic stroke. So it's reasonable to think that, yeah, maybe we should help out these platelets that are altered with these medications by some new platelets. Let's give them a transfusion. And luckily, there are a couple of smart physicians over in Europe, in UK, Netherlands, and France, who designed an RCT back in 2016, multi-center, that took a look at this question. The question being, should we hold platelets or give platelets to patients with acute intracerebral hemorrhage? Does it improve their outcomes? And before we go further and talk about what they found, I want to talk about who they looked at. So they included patients who are on aspirin, they included patients who are on Plavix or both, and they included only atraumatic bleeds. But just as important as who they included was who they excluded. They excluded subdurals, they excluded epidurals, they excluded if the physician thought that this bleed was due to an aneurysm, so probably most subarachnoids. And they also excluded patients who had intraventricular extension of a bleed. And finally, if it was in your cars to go to the OR within 24 hours, you're excluded from the study as well. But it still leaves an important group to look at. In a group of atraumatic, intracerebral, intraparenchymal hemorrhage who were on these medications. Perhaps they could benefit. And what they found surprised, I think, even the authors, because they went back and forth to try to explain this in their discussion, why we found that the patients who received platelet transfusions did worse. They had worse survival, worse neurologic outcomes. But this isn't just the only example where we try to reason our way to a treatment to justify it, only to be proven wrong by the data. When we see that monitor show a gnarly, grim rhythm and chest compression start, it's only natural for us to want to reach for this and to secure the airway, to intubate the patient. Why not? We have to do everything that we can. And up until recently, I think this went without saying, but in 2017, yes, this is retrospective multi-center, but over 100,000 patients in the study. And what they looked at was for all these in-hospital cardiac arrests, who did better? People who were bagged for the first 15 minutes or people who were intubated for the first 15 minutes. And specifically what they looked at was survival, ROSC, and functional outcomes. And again, these findings were a bit surprising to the community. And I'm going to show the numbers. All these are statistically significant. I'm going to show the numbers for the patients that were intubated compared to those who were just bagged. So they had worse survival. They had less ROSC and worse functional outcome. Now, this is inpatient, but we also kind of see this in the pre-hospital data as well. In this study, when you compared the BVM rescue patients to the intubated patients, then we saw that the intubated patients actually had worse survival again and worse neurologically intact survival. Now we're stuck trying to reason our way back to figure out why this doesn't really make sense to us. And I'll give it to you that intubating protects against aspiration. And yeah, it's a secure way to ventilate a patient. But you can also have esophageal intubation that goes unnoticed, and basically you're not ventilating the patient if you don't do it right. Just as important, perhaps even more important, and we touched on this earlier with some of the talks with the advanced care of a coding patient, is it might distract from what's really important. What's the tried and true for cardiac arrest? Good compressions and electricity when they need it. Epinephrine is a debate in and of itself, but to the best of our knowledge, it improves survival to admission, but not to hospital discharge. But that's not something to be shrugged off, in my opinion. At least you give family a chance to say goodbye, and it can help with harvesting organs if that's the patient's wishes, or we think that that was their wishes. And something that I'm sure a lot of us have seen when we are in a cardiac arrest and a code is, out of courtesy, we stop compressions to let the person intubating pass the tube. And it's during that pause that invariably the brain is melting and the chances of this patient surviving evaporate. So maybe this blade is actually harming patients instead of helping them, which is what we thought initially. Now, bread and butter, something that attracted a lot of us to the field: trauma and bad trauma. And when we get the notification over the phone, that red phone rings, we rush in, we prepare, and sometimes in that preparation, fluids are hung. And sometimes the patient gets those fluids if they're in the really, really sick patients. Now, we've known since the 90s that this might actually be harming the patients. But despite this, it's remained as a relic for care. And I'm sure everybody can think of a time where fluids have been started on a hypertensive patient that came in after a serious traumatic injury. Recently, it's come more clear in focus the role of fluids in trauma. And what I mean by that is how detrimental fluids can be. So this is one study, 2011, retrospective, over 3,000 patients. And they split their group up for traumatic injuries into two: the non-elderly and the elderly. And what they looked at specifically was the odds ratio for mortality. And once you hit 1.5 liters, this was found to be an independent risk factor for death. And there wasn't much variability between that and going over 3 liters, although again, all statistically significant. But for the elderly, they couldn't tolerate it. And I feel bad even looking at these numbers to think that some patients got over 3 liters, and you can see the harm that we cause these patients. So I want to end with fluids because this calls into question the general role of fluids. And fluids is something that's almost ubiquitous. How many times have we gone through shift without ordering fluids? I think it's pretty common for us to reach for that clear bag with the hopes that maybe we're helping out. I mean, that's the common denominator here. But are we really helping our patients? Is this really helping a patient with a viral syndrome who's tolerating PO? Is this helping patients with nephrolithiasis? Is this helping patients with migraines? Ask Ben Friedman. Is it helping our patients or harming our patients with trauma? I think that we're starting to get a better idea of that. But one thing that I want all of us to scrutinize is the recommendation tied to incentive for giving 30 cc's per kg for septic shock, and the indiscriminate adherence to this, especially in our older population. This should be tailored. We should not try to harm our patients. So with that, it's a very difficult job that we have. You know, we stand on the shoulders of giants, but we also have to question them. And the onus is on us to prove that our interventions are effective and safe, to question the roots of our practice, and to go back to that oath that we took at the very beginning of this journey to do no harm. Thank you.
Thank you for ending us, Dr. Gilberti. And that's a wrap, everyone. So from ALL NYC EM and from the Metropolitan Harlem Emergency Medicine Residency, I would like to thank you all. We would love to thank you all for joining. We had over 900 people attend, which is pretty outstanding. We had people from upstate New York, people from New Jersey, people from the New York City tri-state area. We're really happy to have all of you students, attendings, residents. So thank you for joining us. We hope you like this conference. Please make sure you're registered, and hope to see you at our next conference coming up in the spring. Thank you.